Actually, just before we start, I'll just say I've had this promised recurrent laryngitis, so my voice isn't brilliant, so I hope it lasts. Should we start?
Yeah. So, 130...
We're going to begin with some remarks.
Yeah.
No worries.
Thank you.
No worries.
Yeah, kia ora koutou. Thank you very much for coming. Really appreciate it. I just thought I'd make some opening remarks, if I may. You'll pick up a lot from the comments from government yesterday, and a lot of that was focused on financial matters and deficits. I just want to clarify in my own comments, and these messages have gone to all of our staff today in email and also in video form. Why did I actually take on this role? Well, I took on this role for three reasons. The first is I want to ensure that New Zealanders don't have to continue waiting as long as they do now for essential health services that they need and deserve. In my view, the shortest wait is the safest wait, and our most urgent and critical priority is to reduce waiting times. There's some that actually get a lot of public attention, like waiting times in the emergency departments, waiting times for specialist appointments, waiting times for surgery, and all of those are very important and they will be highlighted. But there's other waiting times. The waiting time when you're ready to be discharged and that takes a few hours, or waiting time to see a general practitioner. So I just want to stress that from my point of view, the absolute and most urgent priority over the next few years is actually to get waiting times down, because New Zealanders need and deserve God. The second reason I took on this role is I firmly believe that we can deliver a lot more healthcare out of the actual resources that we have now. And we need to do that. And this is not just a kind of productivity as a financial or commercial construct or economic construct. Productivity is actually a clinical construct, because if we can use the resources we have in the most optimal way to provide as much healthcare as possible, then people who are waiting will have to wait less time. So productivity is not an economic or financial construct for us. Productivity is a clinical construct. And the third reason I took on this role, I would like every single contact anyone has with Health New Zealand Te Whāra Ora to be compassionate. We talk about healthcare, and I want to place on the care part of that word, and we want that to be consistent, that every person actually gets that. So yesterday you would have heard that financial performance of the organisation has tanked in more recent times, and that if that continues, we would face a very significant, characterised as 1.4 billion deficit next year, which is entirely unacceptable, because never before has there been so much money invested into healthcare. Never before have we had as many people, FTEs, as we have right at the moment. One of the problems is that when you have a look at all of that, the uplift in output, services and outcomes for patients has remained relatively flat. And we need to address that, because the New Zealand taxpayer needs to get more value for their investment into healthcare. So the financial issue is important, and we do have to deal with it, because we want to be an organisation defined by our opportunities and not by our problems. And we will deal with that. But I just want to stress the primary focus is on doing more and doing better for our patients. And as part of our move forward, we are going to be moving very quickly to regional devolution. And just to clarify this, it's not 4 new organisations, but we are devolving the provision of services and the commissioning of services into those regions. The new leaders of those regions will report to Margie in her role as CEO, and they will get matching authority and accountability, and they'll translate that through to their staff so we can have decisions made much more quickly, and so that we can access local knowledge and local social capital, which is so important in health delivery and so important in getting innovation. So that's really important for us as we go forward, and they will need to help solve the problems we have. And yes, we have to solve this financial problem, and would it be good if we didn't have it? Of course it would be. And is it going to be a challenge to resolve? Yes, it will be. But it will be resolved, and then we just focus all of our attention on patients. Health New Zealand Te Whareura is a big organisation, and in my view it is quite a bloated bureaucratic organisation, and we want to turn this into a health delivery organisation, totally focused, all its resources, all of its energy going to supporting that front line who actually deliver all of the services. And when I talk about services, there could be personal health services, there could be public health services, we're talking about the range. But that's where the energy, that's where the resources go. And we may have to recontour and recalibrate some of our investments, but we want to just get everything going, get the waiting times down, be more productive to get more services into the hands of patients, their families and communities, and make everything we do infused with the milk of human kindness, compassion, consideration, and empathy, and never forget that we're dealing with people when they're vulnerable. And, I know, like all of you, I know what that's like. I've had a year of just constant problems, health problems with my family, and I just know how complex this is and how vulnerable, even if you know how the system works. And we just want to make that easier. And I fully believe that's entirely possible. But we have to change our focus, we have to change our operating model. A lot of our operating models, a lot of the way in which we work are not modern, and they are unaffordable. And we need to find pragmatic ways of making everything affordable and backing our staff and get those waiting times down. That is first prize. And that is actually the only prize. We have to do that. In the background, we've got to ensure that everything is quality and safe, and that our environments are safe. There's a lot of that to do, but I'm just trying to tell you where the focus is. So very happy to take questions. Thank you.
You're talking about...
Levy, we heard 2 years ago that there was going to be an end to bloated bureaucracy. Yes. There was going to be short waiting times. I mean, is this a fail or what?
Yeah, well, I just want to stress that I'm dealing with the cards that I have been dealt, and I'm not that interested in going back over everything. I just want to put all my energy into going forward. I mean, and we can get Margie to answer some of this herself because she has been here, but it's a complex process. We are where we are, but we have to sort this out in a different way, but perhaps Margie.
Well, certainly in our first 2 years, we've been consolidating and bringing teams together, forming national functions, and we now have some resources that we didn't have when we started, and the timing's right for us to push back more and support regions. That is where the care is delivered. That is where the best decisions are made, closest to frontline workers, but also communities. And so this change will push into regions, responsibilities, as the Chair has said, accountabilities for budgets, and how we use our people resources to ensure we're delivering care and making those decisions closer, but also achieving the national health targets for all New Zealanders, but tailored to how regions would like to have them delivered for their communities.
But that was the promise at the outset, wasn't it, Margie? What's happened that you almost feel like we're back at the beginning? All those things were promised. There was so much aspiration around these reforms.
So merging 29 entities and a total of $26 billion of resources and over 80,000 staff wasn't going to be achieved all in the first 2 years. In our first 6-7 months we did have COVID to address, but going forward we have built some national systems and resources that will help us, and the timing is absolutely right for us to actually support regional delivery and putting in place regional deputy chief executives for the populations and workers in Northern, in Te Manawataki, in Central and Te Waipounamu who will have a voice at our national executive table.
So
Could
that
I just,
100...
so could I
Sure.
so maybe a philosophical shift that I'm trying to undertake here is I believe that the organisation has been too focused on what I call the hardware of the organisation, the institutional arrangements, the structures and the like, and that was probably of necessity because the focus was on amalgamation. And that has resulted in an organisation that is more top-down than bottom-up. I think what I'm talking about, the philosophy, is what I call about the software of the organisation, more of a focus on the leadership, the culture, the operating models, the clinical engagement, the clinical involvement, and the obsessive nature. And maybe it's just different times, but that is definitely the philosophy that I'm heading down, to focus on the software of the organisation. And that's why this regional devolution is really that important. Because I think one of the things that a lot of people don't realise is that local knowledge and local social capital is so critical in health delivery, and it's so critical to innovation. But those are typically tacit or composite. They're not very easy to access. But if you bring everything closer to where that is, then that will actually get an opportunity to flourish. So you're talking now more about bottom up than top down. But we are where we are, and you know, we take your point, but we're not going to be here in 2 years' time having you ask that same question.
So
that I can assure you.
Sorry, so was centralisation, was that, what did it start off with a broad premise, if you like, of centralising everything to Wellington? Is that, did it start off?
Well, I guess these centralisation, decentralisation arguments go in sort of cycles. Personally, I think that, you know, we are now going to take advantage of what has been achieved through centralisation. So it is one organisation and it's a both and. Some things will be in the national organisation where that is logical and where it is rational and coherent. Where it isn't, it'll go into the regions. But we are where we are, and you know, we move that forward. And this is a philosophical thing as well. But we do need to shift more closer to the action. We need to have the voice of the clinical people much more involved, and our decisions should increasingly be made in a clinical frame of reference.
That 100...
Specifically, what has helped New Zealand spending more money on their budget between nurses, procurement, back office staff?
Yeah, well, I guess there's three ways of looking at it. The first is assumptions underlying the original amalgamation. We need to go and revisit that to see if the organisation has been optimally sized, because if you just look at the structure, you'll find duplication or triplication. So it's one thing, it's a good question, was the size of the organisation at the amalgamation correct? Well, we know now it's not, because it's not affordable. I'll ask Margie to speak about the FT and the personnel, because there's interesting context around that. You know, labour markets change and demand and supply changes. So we work, organisations like ours, work on an assumption of a certain level of turnover, and that has really slowed down quite a lot, so that is part of the problem. But I'll ask Margie to talk about the FTE, because in our FTE problem is opportunity as well as problems. Yeah.
Certainly, and if we go back a few years, we were facing into a workforce shortage, particularly in clinical staff, and some of the things that we did early to try to grow both internationally trained nurses in particular, as well as take in our new grads. Over the last 6-7 months, we found ourselves actually overcorrecting much quicker than what we expected, and so our vacancy rates for nurses is at this role. It was at about 12 to 15,
You're paying too much for nurses.
it's a
We
great
pay what nurses deserve.
yeah. Yes, and we did settle some important arrangements with nurses to resource them, but certainly that, as well as 2 years in, we do think we need to revisit and resize some of our functions as we've brought them together. There is more we can do to ensure that we've got our resources focused on frontline delivery.
But we are thousands of FTE ahead of budget.
I mean, you did say it was a good question, so could you just a bit go at answering that specific. In which areas of the organisation is the overspend beyond above budget?
Okay, well, if you're looking particularly at the budget, some of it is in the clinical area, but a lot of it is in the way the organisation has been sized. So we need to optimise the size of the structure. We also need, through the regionalisation, we are looking to see if the structure can be made less complex. It is an organisation, at least in my view, that the management and administrative structures and processes are very complex. So we're looking to try streamline and rationalise that. So there's issues all over the show. One thing I would say that from my perspective, that internal and management controls are much weaker than I would have expected. So we have spending problems all over the show. So we have to address all of those. So it's not just, there isn't a magic bullet here in solving this, it's quite a diffuse problem.
We see the opportunity in regional deputy chief executive roles as they do at a regional level, they will have responsibility and specialist services, but also commissioning and having a joined up approach to how we support community and primary care alongside their local regional hospitals. We see that as an opportunity to get better decision making closer to communities and services.
I just would like to say, I wish I could tell you that we've sorted all this out. You know, a lot of this we're still in the process of working out, because what we've been trying to do initially, and I've only been there a short time, is we're trying to stabilise the situation before we can reorganise it. So as we have more information, we can make that available. But this is very challenging because there isn't just one issue to solve. There's multiple issues. It's quite diffuse.
So that figure you put on it, obviously that just comes purely from the financial deficit, not from...
Yes, the figure that's been put on it is extrapolating out the run rate deficit. So we've had this run rate deficit that is spending more than we've actually got, is about 130 odd million a month, and that's... So that is if you extrapolate, I guess, put a tourniquet and stop that in order to get into a steady state and work within our budget.
And you say that's because you're spending too much on salaries?
Oh, there's just spending, it's quite diffuse, but the organisation is spending more than its budget. And like everyone's household, every organisation, every business, there's a certain level of resource you got, and you need to live within that resource. We are now spending beyond that resource, and that's not sustainable.
Do you need more money?
No, we don't need more money, because I think that right at the moment, we don't need more money. We just need to spend the money that we've got more wisely. And, if I was the government myself, I would want to see evidence that we're getting value from the money that's been invested. And I don't think we've got good evidence of that yet. And so that's why we need to do more with what we've got. And then if we get to a point where we're so massively productive, then maybe the government might look at this in different ways. But we have got a lot of resource. I know the scarcity and narrative of doom argument comes up a lot in healthcare. So we've got, in excess of 25 billion revenue.
28 billion.
28 billion. We've got more than 25 billion of assets. We've got nearly 90,000 people. That sounds like potentially, if you turn things around, that sounds like it could be an abundance issue if you just used everything properly. My own past history right here at North Shore Hospital, where I was the chair like 2009, before you were all born. And our 6-hour target was the worst in the country for ED. It was 61% when it should be 95%. It took us about 18 months to get it to 95%. It was more or less, besides some people coming and going, it was more or less the exact same people that had got the result of 61 that got the result of 95. So it's ways of working, it's operating models, it's encouragement, it's the way management is done. The exact same people, more or less, went from 61 to 95. Okay?
Can I-
So you can replicate that wherever you go. This isn't the first rodeo about this. This can be done, but it does require a different paradigm and a different approach.
But can I
Margie,
add to
you
that? Regions pushing decision making closer to frontline, they are best placed to use those resources wisely to meet those needs. And that's happened because we've had national commissioning and hospital specialist teams set up the information systems to be able to arm them with the information they need.
Is the ministry responsible here? Should they have given you better direction of how to do this amalgamation more seamlessly?
I think that's not a question for us. Certainly the ministry has an important role in monitoring us as well as other health entities, because we need to work together with the likes of Pharmac and other organisations. But certainly we take advice and we work closely with the ministry to ensure they're getting the information they need to be able to inform ministers as their role.
It's a good question, and part of our objectives is to have a much more transparent relationship with all public agencies, because we should all have the same goal in the end, to do the best for our patients and communities. But yeah, I wasn't here, I can't answer that question. Sorry, Nicole.
Oh, yeah, look, there's real concern in the clinical community about this $1 million per month deficit. They're worried about what is going to be cut, what's going to be not provided as a result. And there's also a huge concern in the community about GPs and primary enormous stopping. It's such a lot of money.
It is a lot of money, but the scheme of things, we are a $28 billion organisation, but it is still a lot of money. The pathway that we're going down is not to make cuts in clinical workforce. But we just need to be careful when we say that, because there could be some sort of administrative overlays there. But no, we're not looking to make our savings out of that area, but we are looking to get more productivity out of that area. We're looking to get more clinical services out of that area, but we're not looking to make the savings specifically in that area. Although if there's money that is cost that you can avoid, or if there's waste, of course we would.
And what do you say to primary care? They say that hospitals are just, the focus, they take up so much money, and primary care is flagging. What assurances do you give to that sector?
Yeah, well, and Margie can talk more about this. This is a key part of this regional thing that we keep talking about. Their job is not just to look after the hospital or our services. Their job is also to integrate our services so that we need to stop thinking about structures. We need to start thinking about like an ecosystem, and we need the boundaries between us all to be much more porous. I'm very sympathetic myself to primary care, because it's a critical part of the whole system, and we want to find ways of interacting with them that are different so that we can actually do better for our patients. And look, the whole system in a way is under stress. But when we look at all of the data, you can't always see that. So I think we need to share the data more, and for people to work out, but primary care, a big part of the strategy.
And certainly, again, one of the opportunities of having regional leadership who bring together hospitals and their local community and primary care providers that they fund is to take a much closer look at how we can join up. And certainly we know that we have regions who are already doing that, but this is about accelerating and amplifying that. And they've been enabled by national commissioning teams who've supported that work by setting up the frameworks. Simple examples are where hospitals and local primary care might work together on acute demand, or work that might shift some specialist appointments into primary care if they're supported to be credentialed or trained. There are lots of small micro projects around the country that's already doing that. Papals in counties, for example. We've just introduced and are implementing some purchase unit codes that will enable us to fund providers outside hospital in areas like optometry and physios to support musculoskeletal pathways. So those initiatives, we can set the national frameworks to do that, but actually regions are the best place to implement that because it best suits their communities.
Isn't there concern though here that if you make these cuts at the secondary care level, it's going to push more pressure on primary health care?
Well, we aren't going to make cuts at the secondary care level, because we're not going to make cuts in the clinical. We need to make the cuts, or any cuts we need to make need to be, first of all, avoidable expenditure. because that's the easiest, then waste, and then we need to come to other areas. And that won't be the clinical areas. But I think what Margie's saying is really quite important here, because the closer you get to action, somebody can just pick up a phone and say, okay, we've got this problem, okay, for the next 6 weeks, you don't need this kind of credentialing or permission to get an MRI scan or who knows what. I actually think we should be creating a much more accessible environment for primary care. I think we should have more capacity for less complex admission into hospital, like direct admission even. We should have more access to diagnostics for primary care. There's a lot of things we have to shake out, and you do need to realise that, we're starting to talk about a lot of boundaries. You think the Berlin Wall went down all those years ago, but we've got lots of Berlin Walls to get down. But there's professional boundaries, there's commercial issues, there's all of these things. But for us, our approach is going to be proof of concept. If we've got a good idea, we trial it for 12 weeks. If it works, we pilot it. If it works, we scale it up. We're a big enough organisation to do that. We need to start experimenting more and working with primary care and others to find different models of care, different ways of working, and we can't just be stuck in this normative way, because frankly, it's very expensive, it's not affordable, and patients are many of them are waiting too long. So
can you give us an example of bloat?
Sorry. Do you think it's reassuring that you're going to experiment back and forth between these different types of care?
Of course it is, because that's how you find new ways of working. So then it's all controlled, but you could say, for example, what would happen if GPs had better access to this? And then you do it under controlled circumstances and you see if it works, because it might not. Of course we need to do that. We need to push the boundary. We need to try different things. We need to be much more explorative. Otherwise, how are we going to find new avenues? Some parts of the way for like 100 years. Okay, that's a new world. Okay.
But that was the aspiration to begin with, wasn't it?
It was.
And one of the first pieces of work the Prata Order did was the waitlist time inquiry, and it doesn't appear that anything's changed in 2 years. Are we just going back to the beginning?
I disagree with that. Te Whatu Ora has, our first goal, which was a recommendation of the task force, was to focus on long waiters. And we have reduced the numbers of people waiting over 365 days. And we're now working, very focused on the government's targets of within 120 days. So that has reduced over the time that we've been in place. But we can go further. And again, we did that with national processes. Actually, regionally, we think that there's lots of creative ideas within our hospital, specialist and community sectors in the region to even go further and achieve that for New Zealanders.
Ms. Apa, I've read the notes from last year's annual report. Is it fair to describe last year's $1 billion deficit of one-off items as an indicator of a systemic deficit, and to extrapolate from that?
I don't think that's what our annual report said. What our annual report notes is that there were some one-off transactions that we had to record in that way in our annual report. So that included a large lump sum payment for pay equity, which went to nurses in that period of time. So that is reflective of a number of one-off transactions.
So is it fair to be that you're criticising being treated as trouble last year?
Report deficit, we report particular one-off transactions. If had not been for that transaction, we would have been much closer to break even.
The Prime Minister pointed. Is that fair to be that he criticised you for that, given those were one-off payments?
I didn't hear, and I can only report on what the annual report said. Thank you.
We're just taking what you're saying. And everyone knows what their budget is, and everyone lives within the budgets, and we just don't have to have conversations about deficits anymore. And we've got a lot of work to do around accounting and finance in this organisation, about internal controls, management controls. We've got a lot of work to do there. But essentially, if we just simplify it, people get their budgets, people live within the budgets, and we learn to do more. But there isn't a shortage of money. I mean, I don't think this is a good narrative, because there's a lot of money and there isn't an uplift in performance for that money, and we've got to get that. But look, none of this will be easy. Healthcare is quite challenging. But we are motivated by the fact that there is so much more we can do for our patients. You know, the person sitting at home isn't all that interested in all of this detail. They want their operation to fix their pain. The person who's waiting for their GP visits, not that interested in all of this, they just want to get their visit.
So people will be interested to know, like, what is bloat, what's something you could cut that everyday people could
Well,
understand?
we will reveal that over the next few weeks. I mean, first, in all of these things, absolutely imperative, the first thing we would do is work with our staff and unions. So once we have the information, we will be talking to them first. We'll always do that. We've got processes to follow. We will follow those processes, and then it'll be revealed. But there are opportunities. We need to, what do they say? The pessimist thinks the wind will die down, the optimist thinks the wind will pick up, and the realist trims the sails. That's us. We have to trim the sails.
Sorry, I just want to ask, with the overspending, how are you going to assure Māori and Pacifica, especially in the regions, especially as the establishment of dental whaeora, how are you going to reassure them that everything's going to be okay in the future? Mark.
Well, we have an appropriation that gives us funding for Māori Health, and so our commitment is that that funding continues to be spent on Māori Health. But even within the Māori Health funding, the team are working on how they can make sure that every dollar of Māori Health funding is actually adding to Māori Health outcomes. Of course, Te Whatu Ora Health New Zealand provides a whole lot of services that Māori access, and so it is our job as well to make sure that the resources in screening, immunisation, hospital wait times, Māori have the benefit of those service improvements as well.
The $130 million deficit seems to have appeared in March. Could you explain what was the major cause of it? Was it the pay equity deal? Were there other factors that kind of tipped it over into deficit and a monthly deficit?
Well, I came in June, so
I think at the time, as I've said, we had workforce shortages up until about October, November, and then were able to really, pleasing to us, recruit nurses, but also taking on new grad nurses. That's added to the challenge. But I think the broader issue for Health New Zealand is also, are we to continue to review ourselves and whether we're delivering all of our other functions in the most cost-efficient way. So together, that is part of the reset that we need to do to support making sure that we are using every resource that we've got.
But presumably you don't have too many staff even after you've managed to take on all those nurses. So was the budget inadequate? Was it inadequate this year, or is there something else that's caused it?
We operate with the resources that we have, and so that is our, the issue over the last few months has largely been about Health New Zealand really keeping an eye on our costs and recruitment. Although we, love to have the clinical workforce that we've got, that is part of the internal controls we need to look at to monitor that much more closely.
The question of these new regional organisations, we've obviously gone from 29 DHBs into a centralised system, and now we're going back out to 4 regional organisations. How much money would have been spent in abolishing the DHBs and then reintroducing a system?
Okay, Margie can talk about the DHBs, but we aren't going to 4 or 5 new organisations. It's one organisation. It's just in terms of the leadership, the budgets, the culture, the communications, the decision making that's being devolved into the regions. It's just one organisation. It's one system. So they're not new organisations in that sense. But in terms of the cost of the amalgamation, I don't know.
Most of our change was actually funded from within our baseline from merging district health boards.
And how much will the regional organisations themselves cost? And what will be the kind of governance structure that you have within these new regional organisations?
So in terms of the governance structure, well, as you heard yesterday, I'm now the commissioner that has replaced the board, so that'll be the governance structure. Margie remains as a CEO, and these 4 deputy CEOs will report to her, and it's one structure. That's how it works, but their focus is on a particular region and the devolution, but we don't want them just working within that region across those, because we don't want to land up with unintended consequences Yep.
Are you planning on appointing co-commissioners?
No.
No.
Sorry, just following up on your
Oh,
question.
myself?
Oh, sorry.
Oh, sorry.
Right,
Yeah.
governance, yeah.
Okay, so I'm entitled to appoint up to three deputy commissioners, and I'm just thinking about that. I'm actually, just for the record, formally, I'm not actually the commissioner until tomorrow. Okay.
Can you explain for people what the difference is between you and, say, a couple of other commissioners compared to the board?
So the way the law works, as a commissioner, you replace the board and you have all the responsibilities and powers of the board. So effectively, that's a change. It's quite a serious step for the government to take. I can assure you it's a responsibility that I intend to take extremely seriously.
Do we have a last question?
Yep.
When are we going to be selecting those three deputy commissioners?
I'm just thinking about it at the moment. You don't have to have all of them. You're allowed to have up to. Decision-making rests with the commissioner. The deputy commissioners are usually appointed in terms of supporting the commissioner.
Just following up on this question here, you said, Ms. Apa, that your job is to operate within the resources you've got. But clearly that hasn't happened. That is the problem here. That's why we're here today, isn't it? You haven't done that.
Yes, and also to signal that we want to move more decision making to regions, and as part of that take some layers out between the board and what patients and communities experience and services. No, this will actually take out a layer, so we're reducing our management layers.
Professor Levy, I know this is a kind of brutal question to ask in this context, but
Then don't.
you've worked with Ms. Apa at counties, you know her well, obviously, but she said 3 years to get spending within constraints. Do you have
2 years, just to
2
correct.
years. She said 2 years to get spending within constraints. Do you have confidence in her long term?
So, yeah, to answer that, and fair question. So I've just been appointed. What I can and will say is that I've been impressed by Margie's willingness to readjust to a new direction, and the effort that she's making to do that. And I respect that. And long may that continue. I'm not fixed on outcomes about any of these things. I'm open on outcomes, so we see how it goes. Right at the moment, do I have confidence in Margie to do what we need to do? Yes, I do, because she's already doing it, and that's what we need to happen. Yeah.
One more question from Nicole.
I was just wondering, do you have metrics for the next 12 months? What are going to be your measures of improvement over the next 12 months?
Yeah. Okay, so, I mean, the organisation does have metrics, Margie can talk to, but we're re-looking at everything right at the moment. But the big things, as I've already said, are these waiting times. That's the main thing. So the national targets, including the mental health targets, are pretty critical to us. We've got a whole bunch of other operating measures and a whole bunch of clinical measures. But we're re-looking at everything because we want to focus much more on leading indicators. By leading indicators, things that can allow us to see very quickly where the problems are emerging rather than to have to wait a while. So leading indicators are quite hard to measure but give you a lot of opportunity to make a difference. Lagging indicators, which are really what most measures are, including financial measures, they're kind of historical and they're quite important, but they don't help you intervene early. We need to intervene really early.
But so we're not going to have any kind of measures of success or improvement. It's going to be leading indicators.
Oh no, we will have measures of success, and as we complete our plan, we will actually publish all of that. We intend to be actually quite transparent about all of this, and I'd be happy in a little bit of time, once we're a bit further into, to have this kind of stand-up again. We're happy to be open about what we're doing. We just need to clarify. We have got a plan that we have to have with government quite soon, and that will have all of that in it as well. But we've got a lot of discussion to have with our own people, and we're hoping to bring these regional people on very quickly because they're critical to all of this.
We'll certainly be publishing the national health targets, performance by region and by district, so local people in their community will see how their regional team is helping them achieve those short wait times.
Thanks, everyone.
Thanks very much.
Mr. Levy.